Okay, so we have a gentleman with a high BMI. He was intubated for encephalopathy, decreased level of consciousness. He's also in acute kidney failure and being dialyzed, a little bit fluid overloaded. We're taking 1 liter out at the moment. He is currently on PC-PSV, 50% FiO2, delta P of 15, and a backup rate of 20. So volumes, everything seems okay. When we go to the volumes are a little large. I'd have to do the 6 to 8 cc's per kilogram measurement. The guy wasn't measured yet, but we should see to do 6 to 8. But right away when you put the electrical impedance tomography on, you notice right away the distribution of ventilation to the dorsal region is poor. It's only 4%, and even the mid-dorsal region as well. So this will become a reference for us. He's quite large. He has a very, very large abdomen. So we're going to try Aprv. Currently we have a mean pressure of 16. We're at 25 of P high, so we're going to use that plateau to transition to Aprv. 25 there. Expiratory termination, we use the auto release that will trap, will stop the descent from your P high to P low when the end expiratory termination is 75% of the peak expiratory flow, and it measures it. It measures it for you. Okay, so let's actually accept all of these values, and we're going to see what happens when we transition. We'll start with 5 and we'll confirm. Give it a sec. Tweaking a little bit here, and then what I'm going to do is I'm going to adjust the P high. We're starting at 25. I'm not going below that because that's what the plateau was on the previous mode. So I'm going to do 25, 26, 27. I'm going to jump up right up to 30, and we're going to check if 30 is optimal. We have to open this up. Okay, so let's do that. I'm going to press pause and get right back at you very soon. Give me a sec, guys. All right, it's been another minute or two. Kept on titrating it right up to 30. So we're extending right now the to 30. The releases, expiratory termination. Freeze frame. There. So it's 15. So the PI is 30 and it's dropping to 15 as a P low. So there's a delta of 15. Yes, understand that the volume here, this is all of the lung recruitment over 5 seconds. This is a passive release, okay? A passive release, and it's measuring that. So often when you're using Aprv in the recruitment, a fully recruited lung and a release to ambient pressure will give about 10 cc's per kilogram of ideal body weight. Obviously studies have to check that out if, because we have the 6 to 8 is a protective lung, but with Aprv things are a bit different. But while we're doing this, we're guiding it with electrical impedance tomography. Right now, the pressures and the pressure over time for recruitment with Aprv during this phase, the most important is to open up everything. We want to get everything open. This guy had complete, dorsal atelectasis. So, the tidal volumes may have been smaller, but when you have only half a lung to deal with like 600 to 700, and now you might have a whole lung to deal with, you know, higher volumes, then great. Now, obviously, the high tidal volumes, this means that we should be weaning down the P high. I'm not going to leave it there, but we're still in a recruitment phase, and when we're in conventional and we're doing recruitment maneuvers, that is a dangerous part. You know, recruitment maneuvers, there's possibilities. So it's the same thing here with Aprv. We're tolerating pressures. We're looking at opening up the lung, and then after we will find the P high with the best compliance. From there, lung recruitment could occur, and that P high may not necessarily be required to be that high, and then we can wean down. And like usual, the P high, just like your pressure support or anything else, as the lung improves, it needs less pressure, the tidal volumes will go up, so that's how you know to wean your P high. So it's like any other mode of weaning. So over here, we're comparing the previous mode to Aprv, and we see here that the end expiratory lung impedance percentage is a gain of 146%. So we have, you know, 1.5 more end expiratory lung volume. Like we've recovered, you know, functional residual capacity, which is good. There's no losses really anywhere. So I'm going to create a report here. And then you can also just customize. Yeah, so obviously the compliance is way better in in Aprv. So we're doing this, you know, to pretty much justify step by step. You know, we know compliance, we know distribution, and I'm gonna press pause so we get some more information for you. So over here we're looking at the end of inspiration. So end of inspiration, you can see that everything was on the ventral, mid-ventral, very poor distribution dorsally, transitioned to Aprv, the higher mean air pressure, allowing now more distribution to be occurring to the ventral region. This can, you know, 5, 10, 15 minutes, an hour, 2 hours, you know, we can look at this and we don't necessarily, you know, have to touch anything and just see how it progresses. The tidal volumes though are quite high over here. So I want to kind of hurry up and get down the P high. I just want to look to see how it's coming along. Not too bad. Right here. All right. So we're really opening up the lung well. Okay, so with the electrical impedance tomography, all right, we can look here, and when the patient was on conventional mode over here, the compliance was there was a 47% compliance loss. So there was all this white means that the compliance is really bad, and that the lung is at risk of atelectasis, lung collapse. And indeed, that is what was occurring. So everything is making sense clinically. The results, you know, just don't blindly believe them, but this is what we would expect. We see the yellow here, this yellow area. We don't want yellow. It shows cyclical opening and closing, lung instability, puts the lung at risk. We see here that now that we're at a P high of 30, we have a reduced cyclical opening and closing from 21% to down to 6. So everything is optimal here. This here is looking at lung compliance. If there was any over distension, it would start appearing in orange. There is 0 orange. In fact, all we have is a better lung recruitment. There's less, there's an improvement in compliance. There's no atelectasis occurring here. We have over here, we have, as these impedance values increase, means that we're increasing the functional residual capacity, the end expiratory lung volume. And I'm really concentrating on 3 and 4. I want to see a significant amount of increase here because that's where there was no ventilation. So we see that over time, 65 and 11, 74 and 14, we are recruiting. So we're recruiting on all levels, and it all depends, how fast you want to go. Do we just keep it at 30, aware of this tidal volume here that's really a release, right? It's not pushing 1 liter into the lung from a peak level. The patient is holding at 30 of pressure for 5 seconds, recruitment's occurring, and a passive release that is very brief, right? Stopping only, see, right here you can see. See, notice the release here, look, it stops right there. It doesn't go down to 0. So we're not having these large delta P fluctuations. What we're seeing probably is that with Aprv, you're using pressure over time. You're getting a lot more recruitment, which is evident when you start using the Pulmovista a lot, and that these are just the volumes of a completely open lung being released passively to the ambient air for a very brief period of time. But more research has to be done on this. It's also nice to mention that we were on 50% here maybe half an hour ago after transitioning to Aprv, taking advantage of the ability to have pressure as well as time to recruit this patient relatively quickly. He shouldn't be on 50%. He's intubated for non-respiratory issues, but he is a heavy patient, and heavy patients are at risk of atelectic trauma and things like that. So very satisfied with this one. Diagnostics. Okay, again over here, this was the issue when we were on PEEP of 10 on pressure support. Well, it was PC-PSV, so it's kind of flow cycled ACPC. And then after here, we just started the Aprv here. But already, look, it went down. There was a gain in 30% improvement in compliance. And then after we left it there, but just over time, look, we see now that the white is completely disappeared. There's a little hint of an orange at 6%. We're going to keep it there for a little bit longer. Then after, we can also test it this way. I didn't touch anything. And then over here, it's showing compliance win, compliance loss. We only have compliance wins, okay? 0 compliance loss. With that, so understand that this isn't just, blindly allowing this release. Everything is being evaluated and everything is optimal here. Then after so that's recruitable. So you see compliance win percentage. We won 64, 81, 81%. And it's like well distributed everywhere. All that blue is a compliance win in all those areas, showing that the patient has an extremely high recruitability percentage, 162, and we're just keeping it. And look, it's recruiting 187, 220, and it's for that reason that I'm kind of hesitant to move that 30 yet. But that's based on your clinical decision. We could still do 28 and just recruit slower. So why don't we try that? Why don't we just go down right now to 28? Look at the release volumes. And what I'll probably do by the end of the shift is try and keep it maybe around 25, because that's what the plateau was prior. So we'll end up being with the same, you know, PIP and the P high will be exactly set the same, and but we'll be spending a lot more time on the P high level, which will increase the mean pressure. The mean pressure initially was over here. It was 16. Now it's 24. We'll see once we get down to 25. I think it was 22. So we'll still get away with a better mean pressure, but the patient's on room air. So we went from 50% down to 21% quite rapidly, showing that there was significant amount of de-recruitment. Okay, it's maybe another hour about freeze framing. So yeah, very, very good result. We really started to see improvements over here compared to what we started out with. Now what we're going to do now is starting to deal post-recruitment. We're going to start sneaking down the P high, and we're going to want to get this to about like 10 cc's per kilogram. 10 cc's, yeah, 10 mLs per kilogram of ideal body weight, and go there. Not going to go too fast, but slowly do that. Look here, see if we're losing any of the stuff we recruited. Go check the end expiratory lung volumes, the FRC. Keep on doing PEEP studies, looking at the regional compliance, make sure there's no over-distension. Okay, so now we just brought it down to 28. It's still a liter. Again, we're looking at the transition between the PEEP of 10 when we were on pressure support with, you know, the tidal volumes were 10 to 8 cc's per kilogram, but half the lung was not taking part in ventilation. So it's like, yeah, sure, the FiO2 is 50%, the tidal volumes are not too bad, and you know, but we had no idea before putting this on that, you know, there was total de-recruitment. Here, what we're doing is we looked, the minute we transitioned from pressure support to Aprv, you see all of a sudden zero atelectasis. As well, even with this 30, you see zero over-distension. Zero over-distension, even if we're concerned about this. Not forgetting that this is not pushing a P high of 15 and putting a liter, pushing a liter in. This is a CPAP that's at 28, showing that at 28 there is no over-distension when that lung is held at 28. And there is a brief release from the P high to the P low, and this release here is extremely brief because we see at no time does it ever approach the flow of zero. And we know that there's not a huge negative, a huge delta P swing, which, you know, people could be concerned about. It's 14. So we have 28 and it goes down to 14, and this is a release of only about 1 second. Yeah, T low is 1 second, and then we're back up. Now what I'm going to be doing is I'm going to be bringing this down to 28, and then 26 and 24. And if I start seeing you know, loss or compliance issues that are getting worse, then I know that this guy actually really needs a higher P high. Yeah, we're doing good. Optimal is at 30. I have been trying to bring it down to see how the lung reacts. Tidal volumes are still quite large. From PI of 30 down to PI of 26, we're really still hitting a liter. Again, like I said, I'm not worried about that. It just makes sense that pressure over time has fully recovered half of the lung that wasn't present, and I'm not worried about it. But, you know, I'm still not doing it on purpose to try and keep that very high. The thing is that every time now that we start trying to lower the P high here so that people are more comfortable with the tidal volume there, now what you're seeing here is we're losing compliance, and we're starting to have areas that are getting over distension. So it's by dropping it that now the lung is over distending, because things are starting to close up. So really this guy needs to pretty much stay around 30 to 28 p high for now. Okay, so finally the jury's out. This patient needs to stay, at least for now, at 30. Anytime I try and go 28 with the p high or anything, it closes up. So the other thing that we can do, if people are uncomfortable with the higher tidal volumes and the blood gas is normal, what you can do, you will adjust a little bit the tidal volumes with your slope. So because there's a slope here, okay, and the descent is a little slower to go up, the viscoelastic property of the lung allows it to go down a little bit more, just a fraction of a second, and it can play with your tidal volumes. So if you have normal blood gases, then just make the slope ramp up quicker. And that usually, if you're uncomfortable with that, it'll lower the tidal volume. So that way you can stay with the 30 and you're getting closer to volumes that are not going to be of concern. So perfect. All right. I also, since the blood gas was normal, I said, you know what, I'm gonna even terminate the expiration at 75 instead of 80, at 80 instead of 75. Let's see what the new P low is. 15.8. All right. Okay, that's the end of it, guys.